Hi guys, in the last module we were discussing about mechanical injuries wherein we discussed about the different type of injuries under different trauma. Okay, so here we'll be discussing about regional injuries. In this module we'll be discussing about regional injuries, that is with specific region. Okay, with regard to your examination purpose, and it is also important for your clinical practice as well, right? So we will be discussing on, to start with, we'll be discussing on the head injuries, right? The craniocerebral injury. To start with, let's start with head injuries. Fine. See, head injuries, right? It can be broadly categorized into closed. It can also be open, right? On what basis you can say that it is open or closed? It is not dependent on the skull vault. It is not dependent on whether you have got fracture of skull or not. It is important that you need to see the integrity of the dura. If the dura happens to be intact, we can say that is closed head injury. If the dura happens to be torn, right, we can say that it is open head injury. Even though you have skull fracture, but still if the dura happens to be intact, then we have to say that it is closed head injury, right? So this is basically, you can say closed head injury and open head injury. Now to start with, let's start with skull fractures. Let's start with skull fractures. But before discussing individual types of skull fractures, right, we need to know the different trauma that is causing it. What kind of trauma that can cause head injury, we'll be discussing on that. Let us say this is the head of the person, skull of the person, and this is the person, right? If you can have a direct trauma, like you say, like you're shooting a bullet, or there is a heavy blow given to the skull by means of a rock or any stone, not only that, or if there is any, like somebody's taken iron rod, okay, hitting on the head of the person. In all these kind of trauma, you can note that there is direct trauma. There is a direct violence wherein the skull can get fractured. This is another person, like you can see this person falling from height, landing on the ground, right? Landing on the ground, falling from height, you can say here the force will be transmitted through the vertebral column. It is indirectly impacted onto the skull. The person can get skull fracture. You can say that this is an indirect violence. Okay, I told you there is a direct violence which can cause skull fracture. There can also be indirect violence that can cause skull fracture. Okay, so these are the two important type of skull, direct violence and indirect violence that can impact the skull. Okay, so let us look at individual skull fractures. We can say that this is the skull. I'm taking a heavy weapon, right, hitting onto the skull. What kind of weapon it is? It's a heavy weapon. It is a heavy weapon with a broad striking surface. With a broad striking surface, right? You can say wooden plank or something, broad striking surface. When it is hit on the skull, do remember it causes what is called as general deformation of the skull, right? We have two types of deformation which we'll be discussing one more later. One is general deformation, another one is local deformation. So this is general deformation. When such kind of force is impacted onto the skull, we get what is called as a thin fracture line, right? It is so thin, it is a very thin fracture line, thin linear fracture line on the skull, right? It is so thin that many times it is very difficult to be detected in the X-ray and CT. Many a time we just find out only during autopsy as well. Okay, so do remember this type of fracture. This type of fracture is called as fissure fracture. This is the first fracture that we are talking about now. Do remember this is called fissure fracture, and this is the most common fracture among all the skull fractures. Now we'll be seeing on the next fracture. The next fracture, let us say this is the skull, and now I'm taking a weapon. The weapon, you need to look at the nature of the weapon. The weapon is something like this, right? And let's say this is the handle. Fine, this is the handle of the weapon. And what kind of weapon it is? This is basically hammer, right? You must have seen hammer. So what is the uniqueness of hammer? You can see the striking surface is very, very small. It's a heavy weapon, but striking surface is very small. When the trauma is delivered to the skull by means of a weapon like this, what happens? There is a fracture on the skull and the fractures gets depressed. right? There is a fracture on the skull and the fracture get depressed, right? So this is a heavy weapon with a small striking surface. This is a heavy weapon with small striking surface, right? You can take any example, right? The commonest example I told you was hammer. Fine. Now you see such kind of striking surface is given to the delivered to the skull. It produces fracture and the fractured segment got displaced inwards, or you can say it is depressed inwards, and this type of fracture is called, do remember friends, make a note of this, this is called depressed fracture, right? The fracture, there is a fracture and the fractured segment got depressed, we call it as depressed fracture. And you can look at the pattern of the fractured segment. Look at the pattern of the fractured segment right here. The pattern of fractured segment will reflect the striking surface, pattern of the striking surface. It is not the pattern of the weapon. It is the pattern of the fractured segment will reflect the pattern of the striking surface of the weapon, and that is called as signature fracture. Do remember, make a note of this, guys. This is called fracture ala signature, otherwise called as signature fracture, as if the weapon has left a signature on the skull vault. Okay, you can find out the pattern of the weapon from the pattern of the fractured segment. Okay, so that's why this is called signature fracture. But what happens here is, this kinds of depressed fracture, it can cause a lot of complications. It can go into the cranial cavity. I told you it get depressed, right? So it can enter into the cranial cavity. It can cause injuries. It can cause brain contusion, it can cause lacerations, it can cause cerebral injuries as well. It can injure the brain parenchyma, right? So that is why this becomes very, very important. Person can land up with a lot of complications. And if you want to treat this condition, you need to elevate. You can do surgery, surgical elevation of the fractured segment has to be done. Surgical elevation of the fractured segment to be done. So the treatment can be done with the lifting of the fractured segment by means of surgery, right? If it is displaced and it is causing intracranial injury, fine. If it is not causing any injury, we can just manage conservatively, fine. So this is the second type of fracture that we have learned now. Now let us say this is another skull, right? You are hitting the skull. There is a fracture. You can see there is a fracture. And again, there is a trauma, there is repeated blow to the trauma, there is continuously multiple blows to the trauma, because of which you can see multiple fractured segment. You can see multiple fractured segments, right? You can see repeated blows to the skull can cause multiple fracture lines. When there is multiple fracture lines, it can cause multiple fractured segment. Right, these kind of multiple fractured segments, do remember friends, right? If you get the fracture with multiple fractured segments, we can call this as comminuted fracture. Do remember, it is called comminuted fracture. Fine, right? And many times it is often a complication of either a fissure fracture or a depressed fracture. It usually is a complication of fissure or depressed. Right? If suppose you get multiple fracture segments and that is not displaced, you can use another terminology. It's called mosaic fracture, right? Or you can also call it a spider web fracture, right? Spider web fracture when there is no displacement with multiple fracture lines. Okay. So you remember comminuted fracture with multiple fractured segments. That is what we need to remember. Fine. Right. Now, moving further, you can see there is another skull. With the blow which is delivered to the skull, what happens? You can see there is sutural separation, right? I am showing you the posterior aspect of the skull vault, wherein you can see the sagittal suture and the lambdoid suture. With regard to this trauma, whenever there is a blow given to the skull, what happens? You can see the sutural separation. The fracture line is noted along the sutures, right? The sutures will separate, right? When the sutures getting separated, do remember this is called as sutural fracture. This is called as sutural fracture, also called as diastatic fracture. This is also called as diastatic fracture. Fine. So this is called sutural, also called as diastatic. This type of fracture is very commonly seen with, not with the elderly people. You know why? Because in the elderly people, the skull sutures will fuse with each other. It will not fracture. So this is a fracture which is commonly seen among young adults. Right. So this is commonly seen among young adults. Fine. So this is sutural fracture. Now let's see another fracture. So this is another skull. You can see very small skull. You can see this is a skull of a child. Right. Children. Fine. So whenever you get children, right, and you can see the skull is so soft. You can see the skull is very soft. You can see it is elastic, and you can ideally use the word pliable, right? It's very, very soft. Particularly, they say this type of elasticity you can expect up to 4 years of age. 4 years of age. What happens here is, now you deliver a trauma. Now there is a force given to this elastic skull, soft skull. When you press on the soft skull, what happens? It doesn't fracture. Instead, there is a dent in the skull. You can find there is a dent in the skull. There is no fracture. If there is only a dent in the skull, do remember, friends, this is called as pond fracture, which is also called as indented fracture, right? It is also called as ping pong ball fracture, right? Ping pong ball fracture. You have a ball, you press it, right? It doesn't fracture, but you find only a dent in the skull, right? So this type of dent is called as pond fracture or indented fracture. This is usually, if you see, this is a variant of your depressed fracture. You have a depressed fracture where there is a fracture and that got depressed in adult. But this one is a variant of depressed fracture where there is only a dent, there is only a depression without any fracture. Fine. You can see here, this type of fracture is called as pond or indented, right? And do remember, this is commonly seen with any baby born out with obstetric forceps delivery, right? When there is a force on either side of the skull, right? With regard to your obstetric forceps delivery, you grasp the head of the baby, right? You can expect the depression on the skull of the baby. So this is called pond fracture, which is also called as indented fracture. Now there is another skull. You can see, right? Now I am drawing the two tables of the skull, right? You can see the outer table of the skull. You can also expect the inner table of the skull, right? Two tables of the skull we have got. Now what happens, do remember, friends, suppose if I am shooting, right, with a gun, rifle, right? So we have bullet, you shoot perpendicular. Look at the direction of the bullet. Shoot like this. It will fracture the outer table, inner table. It goes inside. Then it is fracturing the two tables and then it comes out. Okay. So it is entering and it is exiting. You can say this is perforating fracture. But now the question is not that. In case if you are shooting the skull with a bullet in this orientation, you can see the skull and the bullet. This bullet is not perpendicular, instead it is shot obliquely. You can see this is oblique bullet, right? Or you can also call it as glancing bullet, right? It's called glancing bullet, also called as oblique bullet. Fine. Here you shoot like this, what happens? The bullet doesn't enter the skull. Instead, it just grooves the skull, it leaves. Right? If it is just grooving the skull, forming a gutter, do remember, friends, this is called gutter fracture. Right? You can remember this is called gutter fracture. It's only a groove. Remember, this type of gutter fracture is commonly seen with glancing bullet. And it has been asked multiple times in your examination, right? Gutter fracture is seen with dash type of bullet. It is seen with oblique bullet or glancing bullet. But again, let me go to the extra edge, right? I'll give you some extra points. See, if you get a glancing bullet, you get gutter fracture. But this gutter fracture itself, you have got multiple types. You have type 1, type 2, type 3. 3 types are there. If the gutter fracture is involving only the outer table like this, you can say this is type 1. Fine. In case, suppose, if the bullet is injuring both inner table and outer table, you can say this is type 2, right? Wherein it is involving both outer table and inner table. If it is involving only the outer table, then you can say it is type 1. right? If it is involving both inner table and outer table, you can say this is type 2. Now there is one more wherein you can see that, right, it will just enter for a brief period, it will exit, right? It will enter and it will exit within a small gap. This is where we get keyhole defect. This is type 3 basically. This is where in the skull we find what is called as keyhole defect, right? We get what is called as keyhole defect on the skull, right, with regard to this glancing bullet. Fine. So do remember I told you 3-1. Number 1, it involves only the outer table, right? And if it is involving both outer table and inner table, you can say this is type 2. And if it is entering and coming out within a short distance, just tangential entry and exit, you can say this is your keyhole, that is type 3. Fine. So all this is seen with gutter fracture, and do remember all this is seen with what type of bullet, friends? It is your glancing bullet. It's your glancing bullet. Fine. So far I was talking about the important fractures in the skull wall. Let me show you all these things. Have a look at it. What you see here is your linear fracture, that is fissure fracture. You can see a thin linear fracture line. Fine. You can as well see here you can see there is a fracture and the fracture got depressed. So this is your depressed fracture, also called as signature fracture. You can see this type of depressed fracture can injure the intracranial compartment. It can intracranial, right, content, right? It can injure the brain. You need to lift the bony fragment. Again, you have this depressed fracture. You can see this is comminuted fracture, wherein you can see multiple fracture lines intersecting each other. Okay, right. So this is your gutter fracture, wherein you can see the outer table is guttered. Here you can see there is a dent in the skull without any fracture. This is an indented fracture, also called as pond fracture. Right. So far we were discussing about the fractures of the skull vault. Now we'll be discussing the fractures of skull base. Skull base. Two important fractures that we have to discuss. You can see that, suppose I'll tell you what kind of trauma that you get. If there is a person who's falling from height, landing on feet, suppose this is the ground, this person lands on feet. What happens is there is no direct violence, but the trauma, the force is transmitted indirectly to the base of the skull. Let us say this is the person falls from height, landing on feet. Let us say this is the ground level. Fine. What happens here is when the person falls from height, landing on feet like this, the force will be transmitted through the legs, the vertebral column and the base of the skull. In the base of the skull, you'll be able to find the fracture line. Fine. What kind of fracture that you can expect? You can see this is the base of the skull, and you know very well this is foramen magnum in the posterior aspect. Here what we can see is, you can see the fracture line in the base of the skull just around the foramen magnum, right? They say that 3 to 5 centimeters around foramen magnum, you can see this fracture line, right? You can see this is the fracture line. Remember, it is around foramen magnum. Fine, this is around foramen magnum. You can see this is a fractured segment, right? You can see this is the fractured segment. Fine. This type of fracture is called as ring fracture, right? This type of fracture is called as ring fracture, which is very important, right? I'll show you what other type of trauma that can cause ring fracture. What you can see here is, you can see this is foramen magnum. Around the foramen magnum, you can see the fracture line. Okay, so this is the ring fracture. Now, let us see. I told you the first type of violence, that is person falling from height, landing on feet. When the person lands on feet like this, the force, there can be fracture in the leg, there can be fracture in the femur, there can be fracture in the lumbar vertebra, right? But the force can also cause injury in the base of the skull. This is one type of trauma. Another type of trauma is when the person falls from height, landing on buttocks, right? When the person falls from height, landing on buttocks, again, the force will be transmitted indirectly to the base of the skull, right? Indirectly, the force will be transmitted to the base of the skull. We can expect ring fracture. And not only that, suppose if there is heavy weight falling on the head of the person is sitting, you take a big rock and put it on the head of the person, again, you can expect ring fracture. These are all the different circumstances wherein we can get the ring fracture, right? I've told you the ring fracture. Do remember this. and they can ask you what is the location of fracture line in the ring fracture. Do remember it is present in the posterior cranial fossa. That is so obvious, right? You can just see, you can have a look at it. It is in the posterior cranial fossa. Fine. Now, I told you about one basal skull fracture. Let me tell you one more basal skull fracture. Suppose if this is the base of the skull, you can see this is the foramen magnum. What happens here is, you take an iron rod, hit on the side of the skull. There is a side impact, right? Impact to the side of the head, side trauma, right? You take an iron rod, hit on the side of the head. What happens, right? I hope you must have seen that Ghazni movie, right? So you must be seeing the kind of violence. Take an iron rod, hit on the side of the skull. What happens? Now the fracture line, you can see the fracture line starts in the middle cranial fossa, one side of the temporal region, right? One side of the temporal region, petrous part of temporal bone. It reaches the middle through the sella turcica. It reaches the opposite temporal bone. It starts from one side, it goes to the middle, reaches the opposite side itself. You can see that the entire skull base is divided into two. The entire base of the skull, you can see the fracture dividing into two, front and back separately. And this type of fracture is called as hinge fracture. Do remember, friend, it is called hinge fracture. Basically, we have got three types of hinge fracture. This is type 1, wherein the fracture line starts from one middle cranial fossa, right? One side of the temporal region. It goes to the opposite side temporal region. This is type 1. Type 1. And this type of fracture is very commonly seen with trauma to the motor cycle rider. That is why this is called motor cyclist fracture. Do remember, this is called motor cyclist fracture. This is type 1. And here is where you see the mobility of the skull base, right? You can see abnormal mobility. You can see abnormal mobility of the base of the skull. We call it as nodding face sign. Nodding face sign, right? So let us say this is type 1. Another type of skull fracture, this hinge fracture is there, wherein the fracture line starts in the posterior side. Through the sella turcica, it reaches the opposite anterior side. From the posterior, it reaches anterior. This is type 2. This is type 2. There is another hinge fracture which is involving the anterior cranial fossa, which is involving only the anterior cranial fossa, right? So that is basically type 3. Fine. So this is type 3. So we basically have type 1, type 2, type 3, and type 1 is exactly in the middle cranial fossa. They can ask you where do you get, where is the site of fracture line in hinge fracture type 1. You need to say that it is in the middle cranial fossa, right? That you can easily see that it is in the middle cranial fossa. That is again very, very important, right? I will show you that. Have a look at it. This is hinge fracture type 1. In case if the fracture involves from this side going to this side, this is type 2. And remember, if it is the anterior cranial fossa, this is type 3. So easy to remember, guys. It's very, very important. Type 1, type 2, type 3. Do remember, this is basically hinge fracture. Now, see, when I was telling about all the skull fractures, let us say this is the fracture, right? This is skull and there is a fracture. Because of one trauma, there is fracture line, right? The person was hit again. There was another blow to give into the skull. There is another fracture line. There was another impact to the skull, and you can see the fracture line starting something like this, right? When you look at the skull, you can see that there are multiple fracture lines on the skull. You can see there are multiple fracture lines of the skull. Is it possible to sequence which is due to first impact, which is due to second impact, and which is due to last impact? Is it possible to find out? Yes, right? Do remember, friends, this is called Puppy's rule. George Puppy was a person who demonstrated this, right? This is called George Puppy's rule. Do remember, it says that whenever there is a fracture line, right? Whenever there is a fracture line, the second fracture will not cross the first fracture line. It will join the previous fracture line, but it will not cross it, right? It will never cross it. Do remember, this will help us to sequence the fracture line due to repeated blows. When you have repeated blows to the skull producing multiple fracture line, you can easily find out which is the first one, which is the second one, and which is the third one, depending on this Puppy's rule. Right, let me say it again. Do remember, in case suppose if you get one fracture line because of first trauma, you can see this is the second trauma producing fracture line. You can also note that the second fracture line joins the first fracture line. The new fracture joins the old fracture, but it doesn't cross it. It doesn't cross it. Okay, and you can also see that this is the third one. It is neither crossing the first one or second one. By looking at this, you can say that this is the first fracture, this is the second fracture, and this happens to be the third fracture. This happens to be the third fracture. Fine. You can easily sequence by means of this Puppy's rule. You can have a look at it. Fine. I'll show you the same thing again. You can see there is a trauma given to the skull wall and it is causing fractures. You can see these are all the fractures. Fine. With the first trauma. There was another shot to the skull vault producing fracture line. You can see this is producing another fracture line, but look at the second fracture line. It is cross, right? It is joining the first fracture line, but it does not cross it. It doesn't cross it, right? It is joining the previous fracture line, but it doesn't cross it. So you can easily find out which is first one and which is second one. And do remember, this George Puppy's rule, the Puppy's rule, is not applicable only for the blunt trauma to the head. Not only that, even it is the skull fracture due to gunshot injury, right? Whatever may be the type of injury, if you have a skull fracture, this Puppy's rule will be, you will be able to apply this Puppy's rule. Fine. So I repeat it again. Do remember, the second fracture, the new fracture will join, but it will never cross, right? It will never cross the old fracture. Fine. So do remember, this is basically Puppy's rule. Okay, let us look at the clinical features of fractures of anterior cranial fossa. Right? What do you get? What are the different findings that you get in anterior cranial fossa? We can get what is called as CSF rhinorrhea. Right? We can get what is called as CSF rhinorrhea, CSF leaking through the nose. Fine. And how can you find out whether it is basically CSF or not? Whether it is basically CSF or it is the inflammatory secretions because of the person suffering from running nose, cold. Right? If it is CSF, do remember, certain biochemical tests will be able to tell you. Right? You have what is called halo sign. Right? And not only that, you need to look at the presence of glucose and protein. Here, if it is CSF, glucose will be more, protein will be less. Right? But if it is inflammatory secretion, it will be exactly opposite. Moreover, one more important thing is you need to look for something called as beta-2 transferrin, which is so specific for the CSF. Okay, so the person can have CSF rhinorrhea. Not only CSF, you can as well expect bleeding from the nose. Bleeding from the nose. Right? There can be paresthesia or anesthesia in the tip of the nose. In the tip of the nose. Fine. You can expect black eye, right? Periorbital hematoma. So these are all the features that we can expect in anterior cranial fossa. In case if the person suffers from fracture middle cranial fossa, what if the person is having a fracture in the middle cranial fossa? Here what we can see is, we can see CSF otorrhea. We can see CSF otorrhea, right? CSF leaking from the ear. Right? If the tympanic membrane is torn, you can get CSF otorrhea. You can as well expect bleeding from the ears. Bleeding from the ears. And most importantly, we find what is called as battle sign. What is battle sign? We can expect, we have already discussed about this battle sign in ectopic bruise. Battle sign is basically ecchymosis in the mastoid region that you can expect in this fracture middle cranial fossa. We can expect battle sign, and we can also expect facial nerve palsy. Right? Because we know very well, right, the course of facial nerve is in the middle ear. So whenever there is a fracture, it may injure the facial nerve as well. You can expect the facial nerve palsy. Sometimes you can expect CSF rhinorrhea as well. Right? Very rarely you expect CSF rhinorrhea. Why there is CSF rhinorrhea in middle cranial fossa fracture? because through the eustachian tube, you can see some kind of CSF dribbling. You can expect that it is flowing out, leaking out through the nose, right? So in middle cranial fossa, we can also expect CSF rhinorrhea, okay? And as well, you can expect hemotympanum. There can be blood collection behind the tympanic membrane. So all these features will say that it is fracture middle cranial fossa, right? All these features will tell us that it is fracture middle cranial fossa. If there is fracture posterior cranial fossa, the person can have some boggy swelling in the nape of the neck, right? But these two are very important for examination purpose. Do remember fracture anterior cranial fossa and fracture middle cranial fossa. Guys, now we'll be discussing on coup and counter coup injury. What is coup and what is counter coup, right? Coup injury is something where the injury present at the site of impact. At the impact site, we have coup injury. Counter coup injury is something where you find that injury opposite to the site of impact, right? Opposite to the site of impact. So we have coup and we also have counter coup. But do remember, though we are discussing this coup and counter coup injury in the brain, but still it is also seen in other organs like liver. You can see that in lungs, you can see that in spleen, other organs as well. You can see this kind of coup and counter coup injury. But here we'll be discussing primarily with regard to the brain. Okay. So remember again, coup means at the site of impact. Counter coup is opposite to the site of impact. But this kind of coup and counter coup injury is commonly seen, right? Or you can say it is very rarely seen less than 3 years of age. Right? In children, it is not so common. It is very, very rare below 3 years. And not only that, this kind of injury can be due to the result of blow trauma, or it can also be due to the result of fall. Blow is something you take an iron rod, hit at the head of the person, that is giving a blow, right? Person is standing, you push him back, the person falls backward, there is an injury in the occipital region, right? The other lobes of the brain will also get injured, that is fall injury. Right, you have blow and you have fall. Both this will cause coup and counter coup injury. Fine. And do remember, this is usually seen with head is mobile. Right? In mobile head should not be fixed. Head should be free. Right? Only when the head is free. Suppose if there is my head is fixed. You take an iron rod, hit on this side, right? Head is fixed totally, it doesn't move. You don't get that kind of coup and counter coup injury. But still, now you see my head is free, my head is mobile. Somebody is hitting, right? You can see the head is free to move. The head will move freely. The brain will also move freely inside. You can expect coup and counter coup injury, right? So do remember, this is commonly seen only when the head is free and mobile. Fine. So now we'll be discussing on that. So though you have lot of theories, various theories put forward to explain this. The most important one is struck hoop theory, right? Struck hoop theory, which is basically, you can say, vacuum based theory. Whenever there is a trauma, whenever there is an impact to one side of the skull, there can be appearance of vacuum on the opposite side that will predispose to this counter coup injury. Fine. So just do remember, this vacuum theory is important for this kind of trauma, right? I can show you that. Have a look at it. So you can see this is coup, this is the site of impact, and when there is a site of impact here, that is coup injury will be present opposite to the site of impact as well. So that is called counter coup. That's called counter coup. So we'll be discussing all possibilities of coup and counter coup injury. So we'll discuss about that. Fine. So you can see, most commonly you can see, suppose this is the person who is falling backward. There is an impact in the occipital region. You can see there is an impact in the occipital region. This is coup. But because of the occipital impact, you can see there is contusion on the frontal lobes as well. So this is basically counter coup. So there is an occipital impact with frontal lobes getting contused, right? So this frontal lobe contusion is the most common counter coup injury. right? They can ask you which is the most common contracoup injury, most common site of contracoup injury. The most common site of contracoup injury is this, the frontal lobe contusion with occipital impact, guys. So do remember, I have shown you this so that you will have a better memory about it, right? So do remember, there is an occipital impact, but frontal lobes will be affected. This happens to be the most common site of contracoup injury. Contracoup injury. And if you look at the different lobes of the brain, the frontal lobes and the temporal lobes are more prone for contracoup. They are more prone for contracoup injury because the base of the skull in those regions are very rough, right? They are very rough, right? They are so irregular. So these frontal lobe and the temporal lobe will be more commonly injured because of this contracoup trauma, right? So do remember, keep that in mind. Fine. So going forward, let us look at the different possibilities as I told you. Right? Sometimes what happens, you will not get any kind of injury in the coup site. I take an iron rod, you can see that, suppose if this happens to be the cranial cavity, I am taking the section of skull, right? Coronal section. You can see this is coronal section, and you can see this is your brain parenchyma, right? You can see this is the brain parenchyma. This is one half, right? This is the other side of the lobe of the brain. Suppose if I take an iron rod, hit on this side of brain, right? If I'm hitting on the right, let us say this is right side and this happens to be left side. If I hit on the right temporal lobe, right, you may get injury on the coup side, but you will also get injury on the contracoup side. Fine. So this is basically coup and this is contracoup. This is contracoup. Fine, right? Now what happens, when you hit on this side, sometimes you may get only a mild injury in the coup side, very mild injury, but contracoup will be very, very severe. Or sometimes what happens, you won't get any injury on the coup side. Coup side, it will be perfectly fine, but still on the contracoup side, we can get injury. Right? That is another possibility. Right? That's what I told you. You may get mild or no injury at the coup side, but you may find very severe injury at the contracoup side. Right? Very severe injury at the contracoup side. Right? When there is an occipital impact, just now I told you guys, when there is an occipital impact, the frontal lobes will be contused. Right? So this is the most common contracoup site. I told you this. Suppose what if the person falls frontal, on the front? There is a frontal impact. Coup side. Do you get any injury in the occipital lobe? Never, you don't get that. Right? When there is a frontal lobe, occipital, when the frontal impact on coup side, you don't get occipital lobe to be injured because the inner surface of the occipital bone is very smooth. You don't get this type of any injury. This is again very, very important. Suppose if you hit temporal region on one side, you will get injury on the opposite side, right? So this is fine. You will get contracoup at the opposite temporal region, opposite temporal lobe. This is expected. But sometimes what happens, even though you have an injury at the coup side, one side temporal region, you not only get the contracoup site at the opposite side lobe, we also get contracoup lesions in the contralateral surface of the ipsilateral lobe. Okay. What is that? Don't get confused. It's very simple. It's very, very simple. If you get coup injury at one side temporal region, we also get contracoup injury at the opposite surface of the ipsilateral lobe, the same side lobe. That is because we have what is called as falx cerebri. When there's a violent impact to the side of the temporal region, this brain lobe will go and impact on the falx cerebri. You may get contusion at the same lobe itself. Opposite surface of the same lobe, right? So that is what I told you. You may get contracoup lesion on the contralateral surface of the ipsilateral lobe. contralateral surface of ipsilateral lobe. Or don't make it so complex, you just keep it simple, opposite side surface of the same lobe. Opposite surface of the same lobe. That's quite very easy to remember. Do remember, friends, I've told you all the possibilities that you can get in coup and counter coup injury. One, do remember, when there is an occipital impact, frontal lobe will be contused, but the reverse is not true. When the frontal impact, occipital lobe doesn't get injured. Fine. So do remember about this coup and counter coup injury. Guys, we'll be starting with the intracranial hemorrhage. In this intracranial hemorrhage, we'll be discussing on multiple hemorrhages depending on the location. Here we have got extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, and we also have intracerebral hemorrhage. So we have got multiple hemorrhages depending on the location. So this intracranial hemorrhage discussion is so important. It is so essential that you get this. This is very common in your examination. Not only in examination, it is also very common in your clinic, right? So you get a lot of cases with intracranial hemorrhages. So we'll be discussing on the intracranial hemorrhages. But if you want to have a complete understanding about the individual hemorrhage, it is very, very essential that you need to have an idea about the anatomy of the meninges, right? You need to have a good knowledge in your meninges structures and the meninges and the content of the particular spaces. So we'll be discussing on the anatomy and then we'll be discussing with individual hemorrhage as such, right? Fine, very good. So let's start with anatomy. Let us say that this is the brain surface, right? So let us say this is brain matter, and above the brain matter we have got pia mater. So this is the pia mater, innermost meninges, right? So pia mater. Above that we have got arachnoid matter, and above that we have got dura mater, and above the dura mater we have got skull vault, right? Let us say this is the bone, skull vault bone. Let us say this is the bone. Fine, right? So this is the basic arrangement. So we've got brain matter. Above the brain matter we have got pia mater, and then we have got arachnoid. Above that we have got dura mater, and finally we have got skull vault, right? So this is skull vault. Fine. So this is the arrangement. The space between the skull vault and the dura mater, this space is called as extradural space or epidural space. What is a normal structure that is present in the epidural space? We don't have any structure over there. It is because normally what happens, the dura is very tightly adherent to the undersurface of the skull vault. You have only one structure present over there that is so important. We call it as middle meningeal artery. Middle meningeal artery that is present in the extradural space. The space between the dura mater and the arachnoid mater, this space is called as subdural space. What is a normal structure present in subdural space? Do remember, here we don't have any specific structure in the space itself, but what happens, there are few veins will pass through the subdural space. It ends in dural venous sinuses, right? So these veins are called as bridging veins. These veins are called as bridging veins, which they normally pass through the subdural space. Fine. And the space between arachnoid mater and the pia mater, this space is called as subarachnoid space, right? This space is called as subarachnoid space. What do you have normally in the subarachnoid space? I know you all will tell we have CSF, good. But in addition to CSF, we also have the arterial structures, that is circle of Willis, right? You have basically the arteries present in the subarachnoid space, right? So basically we have got epidural space, we have got middle meningeal artery. In the subdural space we have got bridging veins. Subarachnoid space, basically we have got this arteries. Fine. So now the point is, you know what is the anatomy, what is the normal structure present in the different space, epidural, subdural, subarachnoid, right? You have understood very clearly. Now we'll go to the next step. What is the next step? You can see that the space between the dura and the skull vault, that is called epidural space. If there is any hemorrhage over there, we call it as epidural hematoma or extradural hemorrhage. Right? What is the source of bleeding in this epidural hemorrhage? Do remember, it is the middle meningeal artery. When it is ruptured, it can cause epidural hemorrhage. Fine. The source of bleeding in epidural hemorrhage, that is middle meningeal artery rupture. Now coming to subdural space. You know very well the space between dura and the arachnoid mater, that is called subdural space. The normal structure which is present over there, it is bridging vein. If the bridging veins rupture, you get bleeding in that subdural space. We call it as subdural hematoma. Right? So the source of bleeding in subdural hematoma is bridging veins, rupture of bridging veins. Very rarely that you get even dural venous sinuses. That rupture can also cause subdural hemorrhage. But commonly what you have to remember is bridging veins. Bridging veins, right? Now let us see the space between the arachnoid mater and the pia mater, that is called subarachnoid space. Right? If there is any hemorrhage over there, we call it a subarachnoid hemorrhage. And what is the structure present over there? That is artery. Right? If it ruptures, we get what is called as subarachnoid hemorrhage. Right? So the source of bleeding in EDH is middle meningeal artery. In SDH, that is bridging vein. In SAH, that is circle of Willis, are the arteries that you have to remember. This is so important. This basic knowledge is very important to understand the pathophysiology of individual hemorrhage. Right? Do remember, friends, I have told you very clearly what are the anatomical structure present in each space. Now we'll be moving on to individual hemorrhage. So let's start with individual hemorrhage. To start with, we start with extradural hemorrhage. Extradural hemorrhage. This hemorrhage, extradural hemorrhage, is one of the very important hemorrhage. It can cause high fatality. Right? But fortunately what happens, it is a least common. It is a least common intracranial hemorrhage in autopsy. You can see that this kind of extradural hemorrhage is not seen in children and elderly people, right? Because you can see that the dura is tightly adherent to the undersurface of the skull wall. You don't get a basic potential space for the clot to evolve. But here, do remember, this extradural hemorrhage is very commonly seen among young adults. In young adults, in the age group of 20 to 40, this is very common, very, very common. Let me tell you the pathophysiology. Let me tell you the pathophysiology of extradural hemorrhage. What happens in extradural hemorrhage? What is the mechanism? Right? If you understand the mechanism properly, you will understand the pathophysiology and you will also understand the clinical features, and it will be useful for your MCQ purposes. So let us see the mechanism. So you need to have a basic understanding, clear understanding about the mechanism so that you will understand the clinical features and it will be useful for your examination purpose as well. You can see that if there is any blow trauma, to the temporoparietal region, side of the skull, right? Side of the skull, temporoparietal region, you can say one important landmark that we have got is pterion. Right? Pterion. What happens if there is a blow trauma to the temporoparietal region of the skull? What happens? It causes fracture of temporal bone. Usually it is a fissure fracture. And you can see that 90 to 95% cases of the extradural hemorrhage will have a fracture associated with that. Right? You can see there is a fracture because temporal bone is very, very thin. You hit the temporoparietal region with an iron rod, you can have fracture of the temporal bone. When there is a fracture of the temporal bone, you can see that there is rupture of middle meningeal artery. Because under the pterion, we have got middle meningeal artery. If there is a fracture over there, that will rupture the middle meningeal artery and it will cause bleeding. It will cause bleeding in the extradural space. Fine? Extradural space. Because of this bleeding, you can see when the bleeding starts increasing, when the size of the bleed become bigger and bigger, what happens is the person will start having increased intracranial tension, brain compression, right? The person will also have brain herniation, right? It will affect the brain stem involvement. The person can die of respiratory failure. The person can die of respiratory failure, right? I've told you the mechanism. The person can die of respiratory failure, right? So this looks very, very simple flowchart, but do remember, friends, every word that I've written is an important MCQ. Everything is keyword. Keyword. You can see that there is a blow trauma to the temporoparietal region, that is terion. There is a fracture of temporal bone. There is a fracture of temporal bone. Because of that fracture, you can see there is rupture of middle meningeal artery. There is a bleeding in the extradural space. When the bleeding becomes bigger, it starts compressing the underlying brain and the person dies. Fine. Suppose if it take an iron rod hit on the right side of the temporal region, do you get EDH on the right side or left side? Right? In other words, is it a coup injury or contra coup injury? Do remember, it is almost always coup. Right? It is usually coup injury and it is unilateral. Right? This is unilateral and it is usually a coup injury. Very, very important to remember. Very, very important to remember. Fine. Right. Now you can see that I told you when the bleeding in the extradural space become bigger, it starts compressing the underlying brain. Fine. But at what amount of blood clot is needed, what amount of bleeding is needed to cause brain symptoms? Right? They say that even 35 ml of blood is enough to cause symptoms. Right? 35 ml of blood is enough to cause symptoms. Right? It's enough to cause symptom. Fine. Fatal may be 150 ml, but here even 35 ml it's enough to cause clinical feature. The person will have the clinical features. Now let's see what are the clinical features that you can see in the person. What are the clinical features? Fine. So this is very important. The person comes to us, right, and he tells a typical history that as soon as there was an impact, he felt unconscious. There was a period of unconsciousness. After some time, he regained his consciousness. Right? He was conscious and again after some time, he becomes unconscious again and the person dies. Right? You can see the person was initially unconscious, then he became conscious and later he became unconscious. You can see that the period of consciousness between two unconsciousness, this interval is called as lucid interval. This is very important, right? From medico-legal perspective as well. The period of consciousness between two unconsciousness, we call it as lucid interval. Lucid interval. Fine. Why this kind of periods that you get, consciousness, unconsciousness, all these things? Do remember, as soon as there was an impact, the person became unconscious due to concussion. There is cerebral stunning and the person became unconscious. And you know very well, concussion is temporary. The person regains his consciousness in some time. The person became conscious. But what happens here? Inside, right, the brain, inside the cranium, the bleeding, it has started. The bleeding keeps on increasing. When the bleeding started increasing and it is started to produce brain compression, right? It started to produce brain compression. The person, again, he became unconscious and he dies. Fine. So the first unconsciousness due to concussion and the second unconsciousness is due to increased bleeding causing brain compression and the person dies because of that. Right? So do remember that is a period of consciousness between unconscious. Why is it so important? For the patient, it is so important because during this period, the patient can give valid evidence in the court of law. Whatever he does, it becomes valid. We are talking about the patient's perspective, right? He can give a valid evidence in the court of law. Not only that, during this period, he can write a valid will. If he writes a will, it becomes very much valid. And in case during this period, if this person commits a crime, is he liable to be punished or not? Right? This person is in lucid interval. He is mentally clear. Whatever crime that he commits, he is criminally liable for that. He becomes criminally liable. Right? So these are all the important points for patient's perspective. What about doctor? Why is it so important for us? This is very, very important for a doctor. Even more important for a doctor. That is because when a patient comes to you during this lucid interval, and the doctor did not diagnose the lucid interval, the patient was discharged. Right? The doctor thought that the patient is fine, he doesn't have any problem, and he discharges the patient. Patient goes home and he dies at home. When the patient dies at home because of the negligent act of the doctor, you remember, when any patient dies due to medical negligence of the doctor is liable to be prosecuted under 304A IPC. That is because death of a patient due to medical negligence, 304A IPC. The doctor can be punishable under 304A. This is very, very important. And that is the reason why it is always ideal to admit the patient in the hospital in any patient, any history of head injury. Right? Any patient with the history of head injury, we should always ideally admit the patient in the hospital, or at least take some imaging, do CT, right? So that you will exclude the presence of this any hemorrhage inside, and particularly the extradural hemorrhage, which is very fatal. Okay, so do remember, this is your lucid interval, which is very, very important for clinical practice as well. Right. So now next talk about another important feature. One, the patient may present with lucid interval, but do remember, you don't find lucid interval in all cases of EDH, not possible. Right? They say around 40% of the cases of EDH can present with lucid interval, not in all the cases. Not in all the cases. And EDH is lucid interval is not seen only with EDH. Lucid interval is not seen only with EDH. It may also be present with the SDH also, that we'll be discussing later. Fine. But if they ask you which is the most commonest cause of lucid interval, your answer should always be EDH. Your answer should always be EDH. No doubt about that. Fine. Now, what is the other features the patient can have? The patient can present with dilated and fixed pupil. Dilated and fixed pupil. That is because third cranial nerve palsy, oculomotor palsy, right? Because of the compression of the brain, because of the increased intracranial tension, compression of the brain, the third nerve will get involved, and the patient can have dilated and fixed pupil. In addition to that, patient will also have contralateral weakness, contralateral hemiparesis. Fine. Sometimes, right? So this is contralateral. Sometimes, what we can find out is, we can find out what is called as Kernohan's notch phenomenon. Kernohan's notch phenomenon. What is that? It is basically a false localizing sign. False localizing sign. Why do we say that it is a false localizing sign? Here the patient present with dilated pupil and ipsilateral. The patient will present with ipsilateral weakness. The patient can present with ipsilateral hemiparesis. So it may mislead us. It may mislead us. Normally we should get contralateral, but here it may present with ipsilateral. It may be misleading us, right? In the diagnosis, you need to be aware of something called this Kernohan notch phenomenon, which is basically a false localizing sign. I'll explain this mechanism so that you will have a better understanding about this. What you are seeing here is extradural hemorrhage. You can see this is the dura mater which is intact. Outside the dura mater, you can see the blood clot. Look at the position. Look at the site of the clot. This is in the temporal region. I told you that is very common, right? And do remember, when there is a blow in the temporal region, you can get the rupture of middle meningeal artery. But it is not always only middle meningeal artery can cause EDH. That depends on the site of trauma. Suppose if there is an anterior impact, anterior ethmoidal artery can get injured, right? If there is a vertex, if there is an impact on the top, right, there can be sagittal sinus rupture can also be there. Fine. And if there is a trauma in the occipital region, there can also be rupture of this transverse sinus. So it all depends on the site of trauma, commonly middle meningeal artery. So let us say, what is the actual mechanism of Kernohan notch phenomenon? Let us assume that this is left side. There is a trauma here. Because of the trauma, there is a fracture. Because of the fracture, there is rupture of middle meningeal artery. Because of the rupture, you can have lot of bleeding here, right? When the bleeding gets bigger, it starts compressing the underlying brain. Fine. And because of that, you can have increased intracranial tension, and you can have all these herniation. You can have what is called subfalcine hemorrhage. You can have foraminal herniation, right? Subfalcine herniation, foraminal herniation. And what is so important is this particular area, uncus herniation, right? The uncus of the temporal lobe, when it is getting herniated, you can see on the opposite side, this particular area, it is impinging on the tentorium cerebelli. When there is impinging on the tentorium cerebelli, what happens? Those fibers in the cerebral peduncle will be compressed. And that is because the person gets ipsilateral weakness. Right? The person gets ipsilateral hemiparesis. That is because of these fibers getting compressed. Because of these fibers getting compressed, we get ipsilateral dilated and fixed pupil. Right? Ipsilateral dilated and fixed pupil. Along with that, ipsilateral weakness will be there. Normally, you should get contralateral weakness, but here you have ipsilateral weakness. That is because of compression of these fibers. We have this called Kernohan's notch phenomenon. This is a false localizing sign, so you need to be aware of this. Fine. So let's go for imaging. Fine. So we have to do non-contrastive NCCT brain scan. We have to do wherein we'll find what is called as, you can see, this is the hemorrhage. We can find biconvex, or we can say lentiform. Right? We can also say it is lens shape. Right? Some people call it as idli shape. Right? All these are extradural hemorrhage. And do remember, this extradural hemorrhage, it does not cross the sutures. Right? That is again very, very important finding that you have to keep in mind. Okay, so you need to differentiate EDH and SDH, right? You can see that EDH does not cross the sutures, fine, and SDH will cross the sutures, fine. Now, what is the management? How do you manage? We have to do surgical removal of the clot. Fine. You can either do craniotomy, right, or you can do burr hole to remove the clot. Okay, so the patient will be fine. You save the life of the person. The next hemorrhage is subdural hemorrhage. Can see subdural hemorrhage. You all know what is the source of bleeding in this. What is the source of bleeding, guys? Yes, it is the rupture of bridging veins. Sometimes I told you even dural venous sinuses can also rupture, but commonly you need to remember it is the bridging veins, rupture of bridging veins. But what you have to remember here is, usually it is acceleration deceleration trauma that can cause subdural hemorrhage. Acceleration deceleration trauma. What is it? Acceleration deceleration trauma. Shaking. You can remember shaking. Acceleration, shaking of the violent shaking of the head. Okay, so that is a very easy way to remember this, acceleration deceleration trauma. Fine. The patient can present with symptoms. Sometimes, if this is the time of trauma, the person can present with symptoms within 3 days, or sometimes 3 days to 3 weeks, sometimes after 3 weeks. Fine. If the person presents with symptoms within 3 days, you call it as acute, SDH. If the person presents with symptoms within 3 days, but within 3 weeks, between 3 days to 3 weeks, we call it as subacute SDH. If the symptoms appear after 3 weeks, we call it as chronic SDH. Okay, so it all depends on the size of the vessel that is involved. Okay, nothing else but the size of the vessel. You can see that acute people who are presenting with acute SDH, 1/3 of the people may present with lucid interval. I hope you remember when I was discussing about extradural hematoma, I told you that lucid interval is not present with only extradural hematoma, it is also present with the SDH. Right? So this is acute SDH. Sometimes they may present with lucid interval, that you have to keep in mind. Okay, let's go forward. What are the causes? So remember, the subdural hemorrhage or SDH is commonly seen with two important group of people. One, it is seen with children. It is also seen with elderly people. Right? It is seen with children. It is also seen with elderly people. Fine. In children, do remember I told you that acceleration, deceleration trauma, you can remember violent shaking. Okay, violent shaking. Fine. Acceleration, deceleration trauma. When do you get violent shaking for a child? When do you get violent shaking of the head for the child? Do remember it is shaken baby syndrome. Shaken baby syndrome. Right? You take a baby, keep on shaking back and forth, the head will move back and forth, right? You can see the skull vault and the dura will be moving in differential directions. The intervening bridging veins will get ruptured. Right? So remember, this is commonly seen with shaken baby syndrome. You know very well that is child abuse. Okay, that is child abuse. Now coming to the elderly people. In elderly people also, this SDH is very, very common, particularly any elderly people with a minor trauma. This is again very, very, very important. They need not have a great trauma. They need not have a severe trauma. Even a minor trauma, right? They'll be telling that 70-year-old man who was going in the bathroom, slipped and fell down. Even that kind of minor trauma, the elderly people are more vulnerable for this SDH. Why is it so? Why elderly people are more vulnerable for this SDH? Remember, I was talking about the meninges. You can see that here, you can see that in elderly people, you can have that kind of brain atrophy, cortical brain atrophy. You can see that the brain will go for shrinking atrophy, age-related cortical degeneration of the brain. Right? If you have been seeing CT scan report of any elderly people, you must be able to see this finding, age-related or senile cortical atrophy. Very, very common. But what happens when the brain atrophies, when the brain shrinks, what happens? The in-between subdural space become larger. Right? It becomes larger and the in-between bridging veins will lose the support. And that is the reason why these elderly people, even with a minor jerk, this kind of bridging veins will rupture and it will cause hemorrhage. But remember, if these bridging veins they rupture, many a times it does not present with immediate symptom. That is because these veins are just veins, small slender veins. It may cause bleeding. Right? It may cause bleeding at the time of trauma. But what happens is over few weeks, the bleeding become bigger, starts compressing the brain. The patient will present to you with after few weeks. Clinical features after few weeks. Right? So chronic SDH is very, very common. Chronic SDH is very common with elderly people. Okay? Why it is not presenting immediately after the impact? Because the veins are so slender, it may cause minor bleeding at that time of impact, but over few weeks, the bleeding become bigger, starts compressing the brain and it starts producing the clinical features. Fine? You can find a typical history, 75-year-old man coming to the hospital, presenting with altered sensorium, weakness of one particular side for 1 week. Right? No history of hypertension, no history of any other comorbid illness. History of trauma present 6 weeks back or 3 months back. When he was going in the bathroom, the floor was wet and the person fell down. The trauma happened few weeks back and the person present with symptoms now. That is because I told you that is chronic SDH. Okay? Chronic SDH. Do remember this kind of specific history. This is very, very important, not only for your MCQ purposes, right? It is also important for your clinical practice. When this kind of patient coming to you, when this kind of elderly person coming to you with this kind of symptoms, you take CT, right? And you can see what are the common clinical features. This is SDH. You can see the common clinical feature. The patient can present with headache, altered sensorium, hemiparesis, dilated fixed pupil, personality change, very typical, personality change will be there. And you take CT, what happens? You will find concavo-convex opacity, right? Concavo-convex opacity. You can say banana-shaped opacity, right? But I would prefer to call it as concavo-convex opacity. You can see, but it will cross the sutures. Right? It will cross the sutures. Fine. EDH, I told you that doesn't cross the suture, whereas SDH crosses the sutures. Right? How do you treat management? Right? You can either do conservative management, depending on the case, or you can do surgical removal of the clot. That can also be done, right? So this is SDH. This is SDH, subdural hemorrhage. So SDH, you can see that you can remember the mnemonic of ABC. What is ABC, right? A for aged person. It is commonly seen with elderly person with a minor trauma, I told you. And this kind of SDH is also common in alcoholics. Alcoholics, very, very common. And B for bridging veins, we know that rupture of bridging veins causes SDH. And it is also commonly seen among boxers, right? There is something called dementia pugilistica or punch drunk syndrome. This is a condition which is seen with people who are involved in boxing for a long time, right? Many years. One of the most important hemorrhages that you can see in the brain is subdural. Subdural. Remember that. And C for child abuse. I told you shaken baby syndrome. Just do remember ABC. We will be able to find out about SDH. And the C can also be used for crescentic hemorrhage or concavo-convex opacity in the CT. Right? So you can just remember ABC, which will tell you important points about SDH. Fine. Now we'll be moving on to another important hemorrhage, that is subarachnoid hemorrhage. Subarachnoid hemorrhage. And you know very well what is the bleed. The bleed, basically it is due to the rupture of arteries. You can say circle of Willis. Right? You can remember BATS. Okay, BATS. Easy to remember, BAT. What is that BAT? B for berry aneurysm. Rupture of berry aneurysm can cause SAH. AV malformation. Rupture of AV malformation can cause SAH. Trauma can cause SAH. And S for stroke, right? Stroke, the patient can have SAH. If they ask you which is most common, see, basically we have got SAH due to trauma. SAH can also be due to spontaneous without trauma, right? Trauma is there, spontaneous is there. Okay. And if they ask you common among both trauma and spontaneous, common one is trauma, due to trauma. Fine. And remember the cause, BATS, berry aneurysm, AV malformation, trauma and stroke. These are all the places where we get SAH, subarachnoid hemorrhage. What are the clinical features? You can see the patient will be having sudden onset of severe headache. They'll tell you the worst ever headache of my lifetime. Right? Particularly when the patient comes with berry aneurysm in the adolescent age or teenage group, sudden onset of worst ever headache of their lifetime, we call it as thunderclap headache. Thunderclap. You can see that this kind of typical description in your MCQ. Typical description, worst ever headache of my lifetime, that is thunderclap headache. The patient will have nausea, vomiting. The patient can also have neck stiffness, right? So you can even find there can be loss of consciousness, or there can be sometimes focal neurological deficit can also be there, right? When we do CT, we'll be able to find out the hyperdense opacity, the bleed. We can see the hyperdense bleed, particularly in the base of the brain. Though we find in all the places, right, but still it is more focused towards the base of the brain. Hyperdense bleed will be there. We do LP, right? When we do LP, we'll be able to find out what is called as xanthochromia. Now, when such patient coming to us, you can take a non-contrast CT brain, wherein we'll be able to find out the hyperdense bleed, particularly near the base of the brain. Fine. And if we took LP, lumbar puncture, we will be able to find out the blood-stained CSF. We call it as xanthochromia, right? More prominent in 4 to 6 hours, right? Xanthochromia, right? And how do you manage? We can do surgery, right? Clipping or endovascular coiling of aneurysm can be done. Okay, so this is subarachnoid hemorrhage. If this kind of bleeding is that you find in autopsy, how do you differentiate whether it is subdural hemorrhage or subarachnoid hemorrhage? What we have to basically do is you take some water, pour it on the brain. Okay, you pour it on the brain. What happens is, if it is subdural hemorrhage, it will be washed away. But if still the bleeding persists, if still the hemorrhage is persisting, then it has to be subarachnoid hemorrhage. This is how we demonstrate SDH and SAH during autopsy. Right? It's very simple. You just pour water. If it is washed away, that is subdural. If it is not washed away, that is subarachnoid. That's an easy way to differentiate. That is very easy way to differentiate.